My name is Michel de Vos. I'm a clinical professor at Vrije Universiteit Brussel. My position here in the University Hospital is Senior Medical Director of Reproductive Medicine. The original definition, which was developed more than 50 years ago by Bob Edwards, IVM involves the retrieval of cumulus oocyte complexes from small antral follicles in the ovary, and the maturation in vitro of these cumulus oocyte complexes from the oocyte germinal vesicle stage up to the metaphase 2 stage.
My name is Ye Yuan. I'm the research director at the Colorado Center for Reproductive Medicine. IVM and IVF are different in the sense that oocyte maturation is being performed outside of the body for IVM. Because of that, then you do not require hormonal stimulations to the patients or very minimal stimulations to the patients. This gives an advantage to avoid syndromes such as ovarian hypostimulation syndrome to some of the patients. After you have collected those matured oocytes, the following procedure of IVF and embryo culture and embryo transfer are essentially identical to the standard IVF.
I'm William Schoolcraft. I'm the medical director at the Colorado Center for Reproductive Medicine. In terms of who can benefit from IVM, it's potentially any infertile patient because it is a lower burden of treatment. There's fewer injections, fewer blood tests, fewer ultrasounds, and the retrieval itself is easier. However, with that said, we're in the early days of IVM, so we're focusing mainly on patients who have a lot of eggs.
My name is Robert Gilchrist. I am a Professor of Reproductive Biology here at UNSW Sydney. I am the research lead in the discipline of women's health and also the head of the oocyte biology research unit here at UNSW Sydney. IVM is for the patient, first and foremost, and the advantages are that it's a user-friendly approach. So the patients receive substantially less hormones or even no hormones, and this means that there are less adverse side effects, it's cheaper, there are no needle injections, and therefore there is substantially less monitoring, so less ultrasounds, less blood tests, and also less consultations with the doctor. So overall, it's a much more simple procedure.
It has many advantages, as I just spoke about, in terms of less medication, easier treatment for the patient. So if we can get the success rate equal to traditional IVF, it'll really become a better treatment because it's so much easier on the patient.
My name is Christian Kramey. I'm the Chief Scientific Officer here at Comedo. When IVM first got started, early 90s, first products in about 2004, the whole point was just to try to get a culture system, something that you could take an egg and put it into that wouldn't kill the egg, that could generally allow it to mature and move forward as best you could. What that took the form of is essentially a culture media, so a salt solution, that contains a few of the key hormones that are known in IVF to play an important role. So this is FSH and HCG. And that's all IVM really was for a number of decades. Actually, it's just a media that contains these hormone supplements. But really starting in the 2010s, it started to kind of become into everybody's awareness that oocytes and eggs in general need a lot more than just hormones and salt water with some sugar in it. And we started to understand, really as a community and as an industry, that these oocytes need at least the signals, if not the actual presence of the support cells in order to actually coordinate and ensure that the maturation process goes off seamlessly, that the eggs get everything that they need to not only mature, but also eventually form an embryo.